Hi everybody, welcome to my channel. I'm Stacy, I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's talk about how to talk to a doctor. I have been a nurse for 25 years at least, and one of the things that I have seen a big shift in is the way that we communicate with doctors and how we treat doctors. I just want to start by saying that everything that I say here is my opinion. Take what resonates with you, leave what doesn't, and if it's not for you, scroll on by, I guess. I feel like this one could get a lot of flack. So let's get into it, and if you like what you see here, then I do ask that you like, subscribe, and follow for more. So when I started as a nurse, there was always this fear for me in talking to the doctor. I remember how terrified I was to just call the doctor. And over the years, I've become less afraid of calling doctors, depending on the doctor, of course. I mean, some doctors are still frightening. But one thing that has not changed is that it's not that doctors should disrespect nurses and people that they give orders to. But I've seen a lot of people talk about how we're level with the doctor, and we're not. We're not at the same level as the doctor. We don't have the same level of education. As far as being a human being, we're all human beings and we all deserve respect, and we should give respect to get respect, etc., etc. But to say that we are at the same level with the doctor as colleagues, I feel this is an inaccurate statement. A doctor has been to school a lot longer than me. They are aware of things that maybe I'm not aware of. They can diagnose, they do prescribe medications, and they are giving me orders. I cannot write orders, correct? So when we call a doctor, we need some information when we call a doctor. We don't write orders as registered nurses, LVNs, LPNs. We do not make orders for patients. Obviously, when you've worked as a nurse for a long time, you develop a rapport with the doctor, you can say to the doctor, hey, last time we used A, B, and C method. How do you feel that would work in this situation? And then the doctor can put in their input. Some doctors just don't even want your input, and I think that's a little bit harsh sometimes too. I do think doctors should treat us with respect, but as nurses, coming from a nurse's standpoint, there are things that the doctor needs when we call them and ask them for something, or we come to them and approach them about a patient. Doctors are seeing numerous patients in a day. Numerous. They can't remember each thing that you might remember about the patient that you've been caring for 3 or 4 days, or a week, or 2 weeks, or a month. They're not going to remember that patient the way you're going to remember them. So they really are dependent on your eyes, ears, and your assessment as a nurse. When you call a doctor, you need to have an SBAR, right? You need to explain to them what is happening. You need to give them your assessment. That would include vital signs. That would include what you're seeing with your eyes. What symptoms are they exhibiting? You need to know what's going on with your patient, and you also need to have some backstory too. The doctor might ask you about some history. You need to gather all of your information before you call a doctor, and that has not changed in 25 years. Doctors they're busy. You're busy. If you get all of the information that you need before you call a doctor, you're going to get a better response and a better outcome. Of course, there's going to be that doctor that asks you the questions that you weren't prepared to answer. It's always like that. But when you're going to call a doctor, when you're going to discuss a patient, you need to have that patient's information in front of you. You need to know what's going on with that patient. You need to know what's been going on with that patient. And you need to give the doctor an accurate picture of the patient, because they're not standing there to see the patient. They're dependent on your assessment of things. You also need to be realistic. Sometimes the doctor isn't going to make a single change in the world. In hospice, sometimes the doctor is not going to make a change. Sometimes the doctor is going to recommend a change. The bottom line is, ultimately, the doctor has the final word. You should advocate for your patients. I will advocate for my patients. I will say, doctor, but are you sure you don't want to look into this a little bit further? Or, I don't know, we've seen this work with A, B, and C. Are you sure you don't want to try this approach with this patient? The symptoms and similarities are very close. If you develop a good rapport with a doctor and you have a respectful relationship with a doctor, they would be more inclined to respect your assessment. they're going to be more inclined to know that you know what you're talking about when you're looking at their patient. Because if you come at them with an attitude and you come at them with very little information, they can't rely on what you're saying, and their license is on the line. When we work and we care for people every day, we put our licenses on the line, right? We worked very hard to become nurses. We worked very hard to become nurses. And so it's very important that we do that job with integrity and that we do that job thoroughly. We should be thorough in our assessments and we should be thorough in our duties. We should be not taking shortcuts, and we should make sure that when we're looking at our patients that we really understand what has been going on with them and what is going on with them. Because, sometimes we get a patient that hasn't been our patient, and we're coming into a situation that's maybe been ongoing and maybe been addressed previously. And so it's really important that you're looking back through notes and other assessments to see what's been going on. Sometimes we don't get a good report. Sometimes we get an excellent report from our colleagues. Other nurses are our colleagues. They're at our level, and they should be giving us a good report on our patients. They should be telling us what's been going on with this patient over the last few days. They should have an idea. There is a running report usually happening, and when you take on responsibility of a patient, it's your responsibility to know what's been going on with that patient historically and right now. I love reading into histories of patients because you find out things that are helpful in the care of that patient. Maybe they've had these symptoms before and they've been treated for this before. Maybe they can't tell you that. Maybe the family doesn't remember what they used before. Medical records in your history and physical that's there, it can be useful, and so can nurse notes from the few days that you haven't been there taking care of that patient. That's why it's so important that we document things too. But when we call a doctor, we really just have to make sure that we have all of our information available that the doctor needs in order to make an informed decision. Doctors are very reliant on nurses giving them accurate information, and that includes lab results, symptoms. There's so many things. There's so many things that you need to know when you call the doctor. But in a hospice setting, when a person is having behaviors, for example, or they are having pain, the doctor needs to know, what have we tried before? What dose are they on now? How often are they taking this medication? What have we tried previously? And what was the reaction of the patient? And how long did they take that medication? Because, sometimes people want instant results, and sometimes we're not going to get instant results in a situation where a person is having, say, agitation, anxiety. Some families don't like to use medications that are sedating, and they will often override what the doctor may recommend for you. So that's important to note too. When you're in hospice, sometimes people are very willing to allow their family to be treated with medications that the doctor recommends. Other times, the side effects that come along with benzodiazepines and psychotropics, antipsychotic medications, are frightening to families when they read them. So it's our job to provide education to the family. Just a side note. Make sure we're always educating the family. But when we're coming to the doctor to give them that information, they need to know, is this family going to allow this change? Because if you call and get an order, you can tell the doctor, hey, we need this order. But if the family is not going to respect what the doctor would like to start for the patient, they're not going to see the results that they need. And that's something that you should also take into account when you're calling a doctor. What have you tried before? What's working? What's not working? How many doses are they taking? What symptoms are they exhibiting now? What is their level of consciousness? What's going on with the patient? The doctor needs to know that very clearly when you call them. And I know we have a tendency to match energies, but in a professional setting, and I will talk about this in another video, in a professional setting, we really have to behave professionally. I'm not saying that anybody should tolerate disrespect. Sometimes doctors are really rude. They're really rude to us as nurses, right? Sometimes they come off really rude, but we have to take into consideration that doctors are sometimes going on very little sleep. They're exhausted. They've been dealing, we don't know what's going on in doctors' lives any more than they know what's going on in our lives. And so just think about the days that you've had a bad day and that maybe your attitude wasn't the best toward your coworkers. We are coworkers with doctors, but we are also not at their level. We are also not making the decisions that we're making. and we are not the person who can make those decisions or diagnoses. When you've been a nurse a long time, you see things, you start to recognize what is happening with your patient. And that is the beauty of working in a field for a long time. You begin to be able to troubleshoot with the doctor because you've seen this, they've seen this, you can work well together. But ultimately, our doctor makes the decision and we carry out that decision. Now, it is our duty as nurses to, sometimes we have to question the doctor. Sometimes the doctor will say something or write something that maybe looks wrong to you. So as a nurse, it is your responsibility to clarify an order, to clarify what the doctor said and repeat it back to them and make them repeat it back to you. They don't like it sometimes, but that's what they do. They're doctors and that's what they do. It is their responsibility to give us an order. It is our responsibility to make sure that order is correct and to follow through with that order for our patients in a timely manner and not delay treatment. And sometimes a doctor is not going to give you the answer that you want. Sometimes a doctor is not going to give you the answer you want, and it sucks. It's horrible when you don't get the result that you would like to see from a doctor. And it's frustrating. And I do feel that if you speak to a doctor respectfully and you tell them, hey, are you sure you don't want to address this further? Are you sure there's nothing else you would like to do regarding this? That is a respectful thing to say to a doctor. But we can't make demands of doctors. We can't talk to doctors with disrespect. They went to school a long time for the education that they got, for the responsibility that they're carrying. And again, I'm not saying anybody should tolerate someone talking down to you or being rude or disrespectful to you. They have supervisors too. So if you don't like something that a doctor did, they have a chain of command to follow too. Ultimately though, we do answer to the doctors, and that is a hard pill to swallow sometimes as a nurse, but we are not at that level with the doctor. Just like our CNAs, unfortunately, are not able to work in the same scope of practice that we are. We have a scope of practice, and a doctor's scope of practice and a nurse's scope of practice are not the same. Are we coworkers? Absolutely, we're coworkers. Are we equal in our responsibilities? I mean, we all have a responsibility to the patients, but ultimately the doctor has the final say, and we are responsible to carry it out. Just like when we ask a CNA to do something for us, obviously something that's in their scope of practice, they are not assessing people, they are following through with something that we have delegated for them to do. A doctor is giving you an order, you are clarifying that order, you are following through with that order and enacting it. That's what we're doing in healthcare. And it's hard. It's hard, especially when you've been a nurse a long time or when you feel that you're right. If you feel that you're not getting the answer that you need, there is a chain of command. There is a chain of command. But I advise you to speak with respect to your coworkers, to the doctors, to anybody that you work with. And that's a whole other video which I would like to dig into because I see it so much over the 30 plus years that I've been in healthcare. How have you had interactions with doctors? Have you had times when you felt like a doctor was talking down to you? Have you had times when you felt like a doctor didn't listen to you or hear you? That's really hard. How did you handle it? I'd love to talk about it more in the comments, and I always do read your comments. Sometimes it takes me a week or two to get back to you just because of school and everything that I'm doing, but I do read your comments. I do respect what you say, and if you like what you see here, then please like, subscribe, and follow for more, and I thank you so much for watching, and I hope to see you soon. Bye-bye.